Hello, friends. I'll be giving a brief overview on this poisoning, which is quite commonly seen and not very uncommon. So it's good for intensivists to have a bit of a clarity on this poisoning because this is a devastating sort of a toxin that can kill the patients. So I wish to acknowledge my colleague, Dr. Pradeep Surali, for helping me develop this content. So of course, we'll have MCQs at the end of it to help all our trainees to answer their ED questions or any other questions that they're taking for SS exams, NEET SS exams, on and so forth. So, please understand. So this is a very severe toxin. Even a very small quantity, as little as 10 ml, can be lethal. So that is the evident sort of a thing or a glaring sort of a feature of this poison. So the potency is quite severe. Even 10 ml can kill the patient. So that is something each one of us should bear in mind, because you may be dealing with a family who may say, he just took little bit. Why are you telling patient is so sick? So as intensive care community, we need to be very clear when someone comes with paraquat poisoning, even a small sip can kill the patient. So that is something we have to be clear when we are explaining to the family. So just looking into what this toxin is all about. So as you see, it has a two methyl groups. It's a dimethyl bipyridinium compound. So that is the name. It's a herbicidal. So as you see, there are two methyl groups and it's a bipyridinium compound. So it was discovered way back in 1950. So for all our listeners, please, just it is important to know that this drug, Paraquat, is pretty much banned in most Western countries. So it is only in India that it is freely available and people end up taking up this poison. And it was discovered in 1950, and then it was made available for agricultural usage in 1962. And once they realized that this is a very severe, has a very high potency which can kill. So this is pretty much banned in most of the Western countries. So, but in India, unfortunately, this is available, and even in Asian countries. So maybe we should also make some regulations to not make it easily available for people. So this is a liquid herbicide. So it is used to obviously kill pests in the agricultural sort of a environment. And it was first used in agriculture in US and Mexico, and later this was banned in these countries. So the case fatality rate following consumption of this is actually more than 70%. It can be 100%. It all depends on the quantity, which we'll talk about. And as I said, 10 to 20 ml of 20% of this compound paraquat is very little. So as little as 10 ml can kill the patient. So that is something you need to bear in mind. And it is like a quite a corrosive. So even it can cause corrosion of metals. So in that way, it is that potent with regards to its topical effect. So the steel and aluminum also, it can cause corrosion. So you can imagine when someone injures, there can be a lot of corrosion that can happen in the oral cavity, in the esophagus, and in the GI tract, and that remains common manifestation. So listen to each of these, because all this can come out as MCQs. So the important thing is, how does it cause such a lethal effect when humans consume this? So what is the pathophysiological mechanism? So basically, it acts at the cellular level, and very simplistically, it causes depletion of the energy source, which is NADPH. So NADPH, as you know, within the cell, it is involved in a lot of enzymatic reaction within the cell. So like in Krebs cycle, Cori cycle, so on and so forth, so whatever energy cycles you take within the cell, NADH is involved, and it causes depletion of this. So cell death tends to happen. So that is the primordial mechanism. And paraquat is basically present in an oxidized form. So once it is ingested, it gets into reduced form. So obviously, since it is in oxidized form, following injection, it becomes reduced. Where does this oxygen go? Oxygen comes out as free radicals. And all the toxicity is due to the oxygen free radicals and reactive oxygen species. So this is the primary mechanism we should understand. It is present in oxidized form. Consume it, it becomes reduced, and it releases a lot of free oxygen radicals, which causes a lot of tissue injury and cell death, and causes depletion of NADPH, which is involved in all the energy cycles within the cell, leading to the cell death. So that is the primordial toxicity mechanism. And this free oxygen radicals and reactive oxygen species. Primarily, two important organs are affected in paraquat, lung and kidneys. In both of these, it causes intense inflammation, as you see. And the hallmark feature of this, most commonest, is pulmonary fibrosis. So that is something which you need to bear in mind. The more potent effect leading to the death of an individual happens due to typical ARDS. So there is an intense inflammation in the lungs, which leads to typical ARDS and which leads to severe fibrosis. And similar things happen in the kidney. And it affects liver also, but the two common organs that are affected is almost always kidney and the lung. And pulmonary fibrosis is the devastating complication of this paraquat. And how does it happen? Because lung, what does lung thrive on? Lung thrives on oxygen, right? So because there is an energy dependent absorption of all the oxygen free radicals, because lung is the source of oxygen. So energy dependent in uptake of all these oxygen free radicals leads to intense proliferation of fibroblasts. So this is the way fibroblasts look. So there is intense and rapid proliferation of fibroblasts because fibroblasts thrive on the oxygen and there are a lot of oxygen free radicals. There is a lot of proliferation of fibroblasts, which leads to intense fibrosis, as you see schematically represented. And there is 10 to 20 times higher concentration of this metabolite of paraquat in the lung because it is an energy dependent uptake of oxygen free radicals that happens within the lung. So that is the mechanism. In the kidney, the toxicity, because it gets excreted from the kidneys, there is a lot of damage to the renal tubular cells and there is a lot of vacuolation. Basically, it causes a lot of vacuolations within the renal tubules and renal tubular necrosis happens. So all this red thing you see is a typical necrosis. So this is the way it causes injury to the lung and into the kidneys. Just a schematic representation, vacuolation in the renal tubules for causing necrosis, energy dependent uptake of radicals causing intense proliferation of fibroblasts and fibrosis that tends to happen. And it can cause similar toxicity in liver dysfunction, although it is after lung and kidneys, then the liver also tends to get affected in a severe form. So if you look at the clinical presentation, so basically you see the X-rays, they typically show features of ARDS and CT shows typical ARDS features, which later on leads to fibrosis, and ARDS can set in within 24 to 48 hours. So it is a very rapid sort of a lethal potency that tends to affect the lungs, and ARDS can happen very rapidly within 48 hours. ARDS can set in. So it is as potent. So it is like inducing a huge toxin into the lungs leading to ARDS. So, and because I told it has a corrosive effect on the GI tract, so they have sort of this is called typical paraquat tongue. There is a lot of ulceration and hyperemia of the lung. And the next picture I'm going to show you is from our own patient who came in with paraquat poisoning. So this was our own patient. You can see there's a lot of ulcerations and there is scalding of the whole tongue that happens. So there's basically a burning and the corrosive effect that you would see on the tongue with intense ulceration. This is our own patient who had this paraquat and eventually he died. So this is the typical feature. We call it as paraquat tongue, and this can be a spotter maybe in some of the exams. And GI tract, as I said, it can cause a lot of esophageal ulcerations. It can cause esophageal perforation. That is something which can happen in paraquat poisoning, and they can form fistulas following perforation. Because esophagus perforates, they can have mediastinitis and all the sequelae due to mediastinitis. And I'm sure most of you know when there is esophageal perforation leading to mediastinitis like Boer house, the mortality is very, very high. So this can typically happen. It can also cause pancreatitis. So it is important if you get a paraquat and they come with abdominal pain, do amylase, serum amylase or lipase to determine if they have underlying pancreatitis. And even if this toxin falls on the hand or on the dermal surface, generally skin is sort of resistant, the dermal action, but still they can have blisters because of the corrosive effect. And if there is lot of spillage of this paraquat on the skin, it can lead to burns as well. So it can cause a typical features like burns. So these are some of the typical clinical features of paraquat. So this is important. How do we diagnose? For all our ICU trainees, it's important to just pay little attention. How do we establish diagnosis? Anyway, family will come with paraquat, but how do you prognosticate? Qualitative and quantitative estimation of severity of Paraquat can be done. So this is important for our intensive care community. So basically, it's a simple test. You have to take either plasma or the gastric aspirate when you get a patient with Paraquat poisoning. Then you need to put sodium dihydroxide. So not many may know how to qualitatively estimate, but there are kits available. If kits are not available, one can embark on doing this. So you have to put sodium dihydroxide into the plasma or gastric aspirate until the pH is more than 9. After you have attained pH more than 9, then one has to add sodium dithionite, 20 drops of sodium dithionite. Once you add sodium dithionite and mix this whatever fluid, gastric or plasma, the color changes into green or black. So this can be an MCQ question. So you mix them, then you get a color like this. So based on this color, you can estimate the sort of concentration of Paraquat up to 2 micrograms per ml. So I'll show you the next slide. So this is the reference value. So if it is this color, then there is no Paraquat. If it is 3, so as you see, the color keeps deepening with a higher concentration of Paraquat, and with 100 micrograms, it turns black. So black, blue, green. So that is the range that you tend to have, where you can estimate that the concentration of Paraquat. Why is it important? Because your prognostication and mortality is very correlative of the serum concentration of Paraquat, which is determined by this Proudfoot curve. So this is all useful for our intensivists. So there is this Proudfoot reference curve, and if it is less than 1 microgram at the end of 8 hours, then if it is a 1 microgram, mortality survival is unlikely if it is in the A group. So if it is more than 1 microgram at 8 hours, unlikely survival. But if it is less than 0.1 microgram at the end of 8 to 10 hours, then likely survival. So this is important to prognosticate, and you can determine the concentration from the test that I just showed you. So these curves are useful, and they have this Paraquat survival curves which are readily available online. So as you see, you have to plot the curve, and if it is less than 1 micrograms at 8 hours, then the survival is around 30%. So that is the sort of, it gives you different survival at different time intervals. And you may have to use, like how in paracetamol we have a curve, like for this also there is Proudfoot curve, so which is a reference curve that it is useful and valuable to tell the families about the likely survival. Because if it is more than 1 micrograms at the end of 8 hours, you can very clearly say that patients may not survive. Okay. And there is something called SIPP score, which is Severity Index of Paraquat Poisoning, which is called SIPP. This is calculated by the time lag between the consumption and the initiation of treatment multiplied by the serum concentration. That is Severity Index of Paraquat Poisoning. So this also can be cited in MCQs. So this gives you the sort of estimate of the severity of Paraquat poisoning. So that's about the pathophysiology. So we spoke about pathophysiology, clinical features, and more importantly, qualitative estimation. Of course, in ICU, I have not elaborated on routine tests. You have to do CBC, you have to do kidney function tests, liver function tests to look into other organ dysfunctions. So mainly I focused on qualitative estimation and severity index of Paraquat poisoning. So treatment, of course, for any poisoning, it starts with airway, breathing, and circulation. But when you are maintaining breathing, you have to ensure that you're not giving too much oxygen, because they have already high concentration of oxygen free radicals, which is causing lung toxicity. You should just about maintain oxygenation at around 90% and not aim at 100%. Activated charcoal is suggested and recommended in these patients at 1 to 2 grams per kg. Early initiation of activated charcoal delays the absorption of this Paraquat and has shown to influence outcomes. And as I said, don't unnecessarily give oxygen to maintain saturation at 100%. 88 to 90, you have to treat them like ARDS. 88 to 90% is good enough. The more oxygen you give, more oxygen-free radicals form, more ARDS and more fibrosis happens. So this is something very important to bear in mind in Paraquat. And nasogastric tube is controversial because it is suggested early on, take a lot of precautions because they have severe esophageal ulcerations. You can cause esophageal perforation. You can take the help of gastroenterologists, and you may have to look at putting Frica's tube, something which is less invasive, but it is suggested because they need to be fed also later on. This nasogastric tube has to be put in with lot of caution and taking a lot of precautions and clearly weighing the risk-benefit balance. And of course, because they have severe burns or esophagitis or esophageal ulceration, you may have to give emollients like sucralfate, lignocaine discus has to be administered to sort of minimize the ulcerative effects that may tend to happen. And ventilation, like any other ARDS, you may have to escalate your oxygen requirement based on the hypoxemia, severe hypoxemia that may be setting in. So you may move from simple mask oxygen to NRBM to HFNO to ventilation. Once they get intubated, generally mortality is very high, and you have to adopt good lung protective strategies like ARDS ventilation, PaO2 to be maintained at 60 to 65, saturation not more than 90 to 92%. Generally, once they get intubated, they tend to have a stormy course and they tend to rapidly deteriorate. So this is the typical course of paraquat poisoning. And someone who has a renal dysfunction, hemodialysis and hemofiltration has to be thought. But there are some studies, when I say studies, they're more of anecdotal sort of a case series which suggests the benefit of hemoperfusion as opposed to hemodialysis. So hemoperfusion initiated within 4 hours has shown to be beneficial. So this is the study from Dennis Oliver et al., where they have done hemoperfusion for 7 sessions for 6 to 8 hours within 4 hours. And they could try to influence good outcomes to get and getting the paraquat less than 0.2 milligram per liter. So how about, so the whole focus is obviously when they have a AKI, you would dialyze, you would do hemoperfusion, but the main mortality is due to the lung toxicity. So what are the strategies to minimize or prevent pulmonary fibrosis? They have tried every other drug, and the one drug which they have commonly used is steroids, immunosuppressants. So methylprednisolone, dexamethasone, and cyclophosphamide, all three have been tried to minimize the lung inflammation that tends to happen. And this is shown to reduce the alveolitis and reduce the fibrosis, but there's no robust data to say it improves the survival or it improves the survival rates and reduce the mortality. So this is one sort of a reference study we have, which is done by Australia and Sri Lankan authors. High dose immunosuppression to prevent death after paraquat self-poisoning. This is the one randomized control trial you can refer to, where they used IV cyclophosphamide 1 gram per day into 2 days with methylprednisolone 1 gram per day to 3 days, followed by oral dexamethasone 8 milligram 3 times a day for 14 days. And they compared this with a placebo. So very, very sort of a strong sort of a trial. And one would wonder, how did they get ethics committee to compare with the placebo, where on one arm they used heavy immunosuppressants, cyclophosphamide, methylpred, and dexa, and the other one placebo. And what did they find? So they had 299 patients, and 147 were in the immunosuppressant group, 152 in the placebo group. If you see hospital mortality, there's no difference between the placebo. Although these are all used as a desperate measures, it did not influence a great outcome benefit. And 3 months mortality also, there was no difference between the immunosuppressants. So we may use all this, even for our patient, we use methylprednisolone and so on and so forth. But when you look at the available evidence, there's no evidence to suggest that this can make and this is the biggest study you have, 299 patients. So there's no benefit with immunosuppressants, simplistically putting. And they've tried to use antioxidants because there are a lot of reactive oxygen species. There's a lot of free oxygen radicals. To circumvent that, they've used N-acetylcysteine, and they've used at the dose that we typically use, 150 mg per kg or 3 hours, followed by 300 mg per kg over 24 hours for 3 weeks. Then they've used vitamin C. All these are anecdotal reports, no robust evidence to say that these have significantly influenced any outcome. But these are more as a desperate measures. Vitamin C, 300 milligram thrice a day, they've used in 10 patients. And they've used desferoxamine. Why desferoxamine? Because iron produces free hydroxy radicals. So this is used as a chelating agent so that there's not enough iron to produce free hydroxy radicals. So it chelates iron and to prevent hydroxy radical production. Then they've used salicylic acid, which is more as a tool to scavenge hydroxy radicals. So these are all desperate measures for all the trainees. Be aware, but none of these have shown to make any meaningful change in the outcome. So what are the recent advances? They've used edaravone. So edaravone is a scavenger. So this is a cell death. So as you see, this is a cell, and these are all the free oxygen radicals that are produced. And Edaravone is used as a drug which is used as a scavenger of these free oxygen radicals. And this is shown to have anti-apoptotic effect and anti-inflammatory effect. So there was one study from China, which is a retrospective study of clinical features and prognosis of Edaravone in the treatment of Paraquat poisoning. This came in 2019. So this study was done in 44 patients where they used Edaravone. It's a retrospective study. So Edaravone in this particular retrospective study was shown to have a protective effect on the kidney and on the liver, but it delayed pulmonary fibrosis, but there was no survival benefit. So all in all the drugs that have been tried has not shown any benefit with regard to influencing great mortality benefit or reducing the deaths in patients with Paraquat, which means it is having a very high mortality, especially when they consume bigger amount, like even more than 20 ml, it can be very lethal. And the final sort of a gospel in this day and age, when there is a lung which is failed due to pulmonary fibrosis, ECMO has been used as a bridge. This is only a bridge because it does not lead to healing. Once fibrosis sets in, they need new lungs. So this is used as a bridge to sequential bilateral lung transplant. There are anecdotal reports and case reports where they have shown the patients have gone to lung transplant, but the toxicity has caused pulmonary fibrosis even in the transplanted lung. So which means it is that lethal. And in India, when they consume Paraquat, very often it will be due to dire financial sort of a reason. And putting them on ECMO, taking them to bilateral sequential lung transplant, recurrence in a transplant patient, all this appears logistically. One needs to question whether one is substantiated in taking them to that. So one has to look at the cost effectiveness, ethical issues, so on and so forth when you are dealing with this. So that's about the whole Paraquat. So we spoke about what it is. We spoke about how pathophysiologically it causes basically NADPH depletion, causing cell death, and produces a lot of free radicals. We spoke about clinical features and what are all the treatment modalities that use. So we'll move to the very interesting bit. So I have 5 trainees who are sitting here who are all very clever. So I think very easy MCQ, so not very difficult to intimidate them. So to Dr. Swati, who's one of our colleagues. So what is Paraquat primarily used for? As a herbicide, it's an insecticide, maybe a fertilizer or a fungicide. Okay, she got the answer right. It's a herbicide. So what is the primary route of Paraquat poisoning? Is it inhalation, dermal absorption, ingestion and injection? Dr. Benjamin. Oh, he got it right this time. Last time he told wrong answers. So this time he got it right. So it's injection. So what is the primary mechanism of toxicity in Paraquat poisoning? Is it inhibition of acetylcholinesterase, oxidative stress and free radical, blockade of sodium potassium pumps, interference with calcium hemostasis? Dr. Patil. Okay, Patil has got it right. It's oxidative stress and free radical. So which of the following is hallmark symptom of Paraquat poisoning? Nausea, vomiting, rash, tinnitus, tachycardia. Dr. Pratibha. Dr. Pratibha. Okay, I think she's got it right. She got a little confused between rash. I think nausea and vomiting is the right answer. So what is the most critical complications associated with Paraquat poisoning? It can cause liver failure, it can cause renal failure, pulmonary fibrosis, hemorrhagic stroke. So, okay, everyone has got it right. It's pulmonary fibrosis. So which laboratory finding is commonly associated with severe Paraquat poisoning? Hypokalemia, metabolic acidosis, hypernatremia, leukopenia. Dr. Swati. Hypokalemia, metabolic acidosis, hypernatremia, leukopenia. Metabolic acidosis. Oh, this metabolic acidosis. Why are you thinking so hard? Not necessarily I have to mention answers in all my presentations. So you should use your analytical mind. So what is the role of oxygen therapy in Paraquat poisoning? Oxygen is always beneficial to reverse hypoxia. Oxygen increases oxidative damage and is used cautiously. Oxygen neutralizes free radicals. Oxygen has no role in Paraquat. So all my team says B. B is the right answer. Which of the following treatment is not effective in managing Paraquat? Activated charcoal, dialysis, corticosteroids, antidote specific for Paraquat. Dr. Pratibha. Okay, she's got it right. D, because activated charcoal is used, dialysis is used, steroids are used. Paraquat is known to cause toxicity primarily due to its effect on which organs? Heart and brain, liver and kidneys, lungs and GI tract, blood and bone marrow. Benjamin. Oh, I got it right. Benjamin has got this time everything right. So thank you, friends. So I request you all to submit your valuable work to Journal of Acute Care, and you can visit my website to react to this lecture. Thank you. Thank you, one and all.